Did you know that Steve Jobs, the co-founder of Apple, used to hold meetings while walking? And Facebook's Mark Zuckerberg has also been holding meetings while on foot? And perhaps you've paced back and forth on occasion just to drum up some ideas. A new study by Stanford researchers provides an explanation for this. Creative thinking improves while a person is walking and shortly thereafter, according to a study co-authored by Marilio Pezzo, a Stanford doctoral graduate in educational psychology, and Daniel Schwartz, a professor at Stanford Graduate School of Education. In 1987, while walking in the woods, Francine Shapiro, a psychology graduate, had an epiphany. During that very walk, the idea of EMDR, eye movement desensitization reprocessing, was born. While thinking of an anxiety-provoking situation, Shapiro noticed that her eyes were involuntarily moving back and forth and that her distressing thoughts suddenly disappeared. She then followed this with a series of successful trials in her private practice. An uncontrolled study demonstrating the effectiveness of a single session of eye movement with 22 clients distressed by traumatic memory, Shapiro began training the clinicians in her approach. And today, there are more than 70,000 clinicians that have been trained in EMDR. Hello everyone, this video will examine the scientific theoretical model behind EMDR as well as the body of research about it. We will analyze it and whether its underlying principle, eye movement, is at all necessary, and whether you should choose EMDR. So get yourself a drink, have a snack and relax. And if you are an EMDR proponent, stay tuned, stay assured, by the end of this video, you'd love to hate it.
Talk to you about to kind of put up a barrier between them and us?
I don't think so. I think I'm just going to focus on you.
Okay, sounds good.
Okay.
So for the sake of getting a little bit of history, I know I screened.
EMDR is an 8-step manualized approach that encompasses several general clinical components such as history taking, relaxation, and verbal reporting of the nature and emotional consequences of the traumatic experience. Additionally, this procedure requires the client to construct and maintain both imaginable representation of memory and the physical sensation associated with the traumatic event. And while maintaining the image, the therapist introduces a bilateral stimulation procedure, such as moving a finger across the client's visual field to elicit side-to-side eye movement. So what's the purpose? The purpose is to elicit simultaneous dual attention to internal inner focus and external stimuli. The client is asked to find negative thoughts, beliefs that accompany the psychological disorder, and to generate a more positive appraisal about the trauma and the experience the client had with it. This latter component is known as reprocessing and is added to the desensitization that accompanies the vividly imagined feared object, situation, or activity. So, every developmental psychotherapy should be based on a solid psychological theory. In EMDR's case, this theoretical model is called Accelerated Information Processing, in short AIP. According to this model, healing occurs after eye movement and other features of clinical protocol unlock the pathological condition. I'm confused. As far as I know, for over 100 years psychotherapy has been successful in treating trauma without EMD. The AIP model defines pathology as dysfunctionally stored information that can be properly assimilated through a dynamically activated processing system. Fancy word, with very little scientific basis, with a language that is designed to give EMDR legitimacy.
So let's talk quickly about the evolution of the PTSD diagnosis. PTSD was introduced in 1980, as everybody here certainly knows. It was from
Keane 1998 highlights no correlation between the theoretical foundation of EMDR and the science of the nature of PTSD, as well as Stanovich 2012, who concludes just the same. In other words, eye movement stimulation is completely divorced from any existing model of psychotherapy and is largely inconsistent with scientific knowledge we have about the nature, acquisition, and modification of fear and anxiety. And up until this point, there's almost no research done to validate the AIP model. I mean, it's been like 30 years and the model is still not validated. Not only that, it's not even close to that point. But EMDR proponents will tell you that this is about to change. I mean, like any moment.
A little longer than a few minutes later.
Like right now.
Many tic-tacs later.
A little longer. It's now 2021. Neuroscience has been the driving force behind the latest developments of how the brain stores and processes memories. So, shall we take a closer look at what neuroscience has to say about EMDR? In an independent study published in the journal Neuroscience in 2018, 24 participants, 12 females, 12 males, between the age of 23 and 37 years, all of which completed the study. So what's curious about this study is that they found that in both experiments, the amygdala, the part of the brain responsible for fight and flight, was deactivated. This though, the research concludes it's not specific to eye movement, which is in line with what we know about behavioral studies. The visual imagery, the image held, along with the instructions given by the therapist, is the main mechanism behind EMDR's efficacy. Again, are you telling me this is the first time we've heard about something like this? Well, sadly, that's not the case. However, before we focus solemnly on psychiatric eye movement, we shall compare EMDR with other evidence-based psychological treatments. The evidence base for EMDR has increased in quantity and quality, and this therapy is now regarded as efficacious in the treatment of PTSD in several clinical practice guidelines. Two well-conducted clinical trials directly compared the efficacy of EMDR and exposure therapy, which is widely researched, empirically supported treatment for PTSD. 60 participants with PTSD were randomly assigned to receive 8 90-minute sessions of EMDR exposure therapy or relaxed training. Ratings of PTSD treatment were gathered pre-treatment, 1 month post-treatment. All treatments were found to be effective. Compared to EMDR, exposure therapy yielded a significantly higher percentage of participants with higher clinically significant change.
We talk about treatment of PTSD and anxiety, looking at new methods, new research, new ways to treat people better, including
a second methodologically rigorous study done by Rodbaum, Austin, and Marsteller in 2005 compared the efficacy of EMDR, PE prolonged exposure, and waitlist control group, that's basically a bunch of people who wait and receive no treatment. Both EMDR and exposure therapy reported significant clinical improvement at post-treatment to follow-up compared to a waitlist control group. At 6 months follow-up, only 5% of participants for PE, prolonged exposure, met the PTSD criteria, 25% for EMDR, and 90% for the waitlist group. Significantly more patients who received PE demonstrated 78% good end state function to 35% of EMDR. I can keep going with this with more studies, but the results are either similar or the margins are insignificant. And I can tell you there is a lot of studies done on this, and they are pretty much concluding the same thing. So I'm not gonna mention all of them, but I will link them in the description below. The aforementioned clinical trials, as well as the additional studies using less rigorous designs, suggested the efficacy of EMDR is generally compatible with that of trauma-focused CVT approaches such as prolonged exposure in the treatment of PTSD. While the head-to-head comparison with other treatment models suggests EMDR is efficacious, the evidence supporting the overall therapeutic benefit of this therapy is insufficient to demonstrate its theoretical model. The only way to find about this is to examine bilateral stimulation, which is central to the effectiveness of EMDR, or so we're told. In order to improve treatment, we have to know what works. We can do this by conducting 2 types of studies: component control studies and dismantling designs. These designs are necessary for the identification of components, the parts that are specific to EMDR. and to test the contribution of eye movements and related techniques to the treatment of PTSD. So we already know EMDR involves several therapeutic procedures, and bilateral techniques are its distinctive feature and are emphasized as essential in its theoretical model, and the effectiveness of EMDR reportedly has. Components control experiments are useful in determining the extent to which its various parts are efficacious, and it will provide meaningful benefits beyond the non-specific aspects of treatment. An example of that would be the therapeutic alliance between the therapist and the client, the therapist's effects, the therapist's competence, the adherence to specific treatment modality, all of which can have a moderate to significant effect on outcome of treatment. So what does the research has to say about this? Rainfree and Spates, 1994, recruited 23 trauma victims, 21 of whom met the criteria for PTSD. Participants were assigned randomly to one of three conditions: EMDR, an EMDR with a laser point moving across the visual field, and EMDR where lights which blinked in the center of the visual field. The results were quite fascinating. They found that EMDR procedures, not saccadic eye movement, were responsible for positive self-report. This study did not directly control for non-specific treatment factors. Baldwin and Heyer in 1996 compared EMDR with an eye constant imagery analog and no imagery control procedure of combat-related PTSD. So this is what they found. They concluded that neither eye movement nor bilateral stimulation was necessary for change, suggesting that imagery exposure may be sufficient for that change. Are you as surprised as I am? Pittman et al. 1996 used a crossover design where participants jumped from one treatment group to another, conducted over two treatment sequences using EMDR and no movement imagery, fixed eye. This study showed eye movement has no clear advantage over other forms of stimulation. Later study, McLean et al. Reported that all participants exposed to EMDR had returned to pre-treatment levels of PTSD 5 years after completion of treatment. Is this new? Actually, it's not new. This criticism has been there for the past 25 years, yet proponents of EMDR still have not addressed it. There is almost no research, no studies done on the effectiveness of EMDR past 5 years. Is it just treating the symptom and not the cause? There's no conclusive evidence about that.
Are you concerned that some people will see this as a wonder cure? Is it a quick fix?
No, it goes along. It's hard work. It takes a good amount of clinical skills in order to implement it. And this isn't just touch the person's forehead and they get better. The client and the clinician really have to be responsible and work at it, but it goes much more rapidly than...
Spence and Rapie, 1998, compared EMDR with no movement imagery that was presented to war veterans with PTSD. The authors concluded that eye movement is not the agent of change, and other non-specific factors are responsible for a high level of efficacy, reported in previous EMDR research conducted without adequate procedural controls. In the early days of EMDR, Shapiro did not conduct randomized controlled trials that are blind. She conducted an uncontrolled study, which does not address confirmation bias, heuristics, cognitive bias, nor did it account for specific or non-specific factors. Blind RCT often minimize bias. That's why they do them, that's why they're the gold standard. And they account for non-specific and specific factors. DeVille, 2012, reports that out of 13 dismantling studies, 11 found no significant benefit to eye movement in EMDR. Still, faced with the criticism, Shapiro expanded the range of saccadic eye movement to include tapping, tactile stimulation, and auditory tones. Here I want to make one point clear. The burden of proof lies with the one that's being criticized, with the claimant. They must prove the critics wrong. So what was her response? Shapiro basically discounted her claim and her previous research on eye movement as a necessary component to EMDR. So far, exists a clear scientific consensus that bilateral stimulation procedures do not contribute to the effectiveness of EMDR, concludes Spates et al. in 2009. The American Psychiatric Association's 2004 PTSD guideline state that dismantling studies show no incremental effect from the use of eye movement or other proxies during the treatment sessions. In question is called EMDR's theoretical rationale. Clinical Practice Guidelines of the Department of Veterans Affairs, Department of Defense 2010 asserts that the data do not suggest that eye movement or other forms of kinesthetic stimulation are necessary. I would like to quickly read through a brief summary found on the Society of Clinical Psychology webpage. Hold tight. The efficacy of EMDR for PTSD is an extremely controversial subject among researchers, as the available evidence can be interpreted in several ways. On one hand, studies have shown that EMDR procedures result in a greater reduction of PTSD symptoms compared to control group receiving no treatment. On the other hand, the existing methodologically sound research comparing EMDR to exposure therapy without eye movements have found no difference in outcomes. Thus, it appears that while EMDR is effective, the mechanism of change may be exposure. The eye movements may be an unnecessary addition. If EMDR is indeed simply exposure therapy with superfluous addition, it brings to question whether the dissemination of EMDR is beneficial for patients and the field." End quote. As you see, serious questions are brought forward of the effectiveness of the eye movement component of EMDR. Did you hear this? They have concluded that while effective, the eye movement component seems to have no effect on outcome, with or without its use. Of course, Shapiro and proponents claim that all those studies are invalid because of confirmatory biases and because researchers did not have specific EMDR training. Oh, I just want to scream. This is reversing the burden of proof yet again. And by the way, judgments and decisions made by experienced clinicians are generally no more accurate than those made by trainees or less experienced clinicians, when both are provided with the same information. I mean, this has been on and confirmed since the 1960s up to date. This is no new information, whether it's an experienced clinician or not. I mean, there is studies, research, and I'll link them below, about this for the past 60 years. Clinicians who use pseudoscientific methods often do not discover that their methods are invalid because it is difficult to ascertain from a clinical experience. A clinician in private practice cannot account for all specific and non-specific factors because of confirmation biases and heuristics and more. Okay, this is getting too long, so let's summarize. The scientific literature supports several conclusions. EMDR is an efficacious treatment for PTSD. Efficacy of EMDR is compatible with that of trauma-focused CBT approaches such as PE, and eye movement and other bilateral stimulation techniques appear to be unnecessary and do not uniquely contribute to clinical outcomes. And after 30 years, there is no convincing evidence saccadic eye movement is at all necessary component to EMDR. On top of that, its theoretical model is scientifically bloated and divorced from what we know about psychopathology. I mean, this is the first thing you need to do about psychotherapy. Its theoretical rationale has to be proven. In 2002, Shapiro emphasized the numerous components that compromise this therapy and claimed, quote, "As with any complex treatment, the elimination of a single component is likely to have little effect." Oh, yes, and I still believe in the butterfly effect. I fully believe in it. I mean, if I start flapping my wings right now, there'll be a tornado at the other side of the continent. This is why more dismantling design studies should be conducted on EMDR. Eye movement is not necessary to EMDR. Then what you have instead is a glorified CBT. And also, incidentally, the 8 steps on EMDR corresponds with the 8 elements found in CBT. Rebranding, baby! So, let's wrap it up. I found it appropriate to leave this quote from McNally, who concluded this about EMDR. What is novel is not effective, and what is effective is not novel.
EMDR in a nutshell.
Hey, I hope you enjoyed the video. If you did enjoy it, I'd really appreciate it if you liked the video, subscribe and hit that notification bell so you don't miss another video. But if you didn't like it, I would still like to know what you think about it. So please let me know in the comments section below. Have a good day, and I'll see you in the next one.